throughout the event. Welcome to Demos's event at the Conservative Party Conference, which we are delighted to be holding in partnership with the Royal College of Nursing. Thank you for their generous support for this event. My name is Ben Glover. I'm the Head of Social Policy at Demos. I lead our work on public service reform. It's great to see so many of you here in the audience this morning. I think you'll probably all agree public services are in a state of crisis. And this is deeply concerning, but the good news, I think, is that politicians are starting to have a potentially quite promising conversation about public service reform. How do our public services need to change? Yes, I think we all agree they need investment, and I'm sure we'll talk a lot about that this morning, but they also need reform. I think their delivery models are outdated and unfit for this era. So with that context, we're going to be focusing in on the health sector this morning, and specifically issues around the health workforce. Again, I think we'll all agree the NHS is in a real state of crisis, and we're potentially about to go into one of the most challenging winters on record. And I'm delighted to be joined by two excellent speakers to be discussing these issues. I should say I'm very sorry Simone Finn can't make it this morning. She's got a diary clash, but I think the two panelists we've got will more than make up for that. So to my right, I've got Nicola Ranger. Nicola is the Director of Nursing at the Royal College of Nursing, and I've just been looking at her CV, and she has a kind of remarkable level of experience in the UK and in the States, very senior nursing roles. So she's incredibly well positioned for this conversation. And to my left, I've got Polly Curtis. Polly is the Chief Executive of Demos, and she's been leading our work recently on Martha's Rule, which Polly will be talking about later on. She's also a non-executive director of the Parliamentary Health Service Ombudsman. So that's the panel. We're going to be we'll finish at 11:30. Sorry. We'll have plenty of time for questions, so do jot them down as you're listening to the speakers. As I said, help yourself to coffee, and really looking forward to the conversation we'll have. So yeah, I'm going to start by asking Nicola to give some opening remarks to kind of set the scene on what the healthcare workforce's challenges that we see today are, and then Polly will pick up and we'll kind of have a bit of a discussion around policy solutions. So over to you, Nicola. Can you give us kind of a state of play where the healthcare workforce is today?
Thank you. Thanks very much, and delighted to be here. I just want to give you a little bit of background before I sort of describe the challenges that we're in. As was said, I am a senior nurse. My clinical background is intensive care, and that has, as was Ben said, has led me to work in both the US and the UK. But the past 10 years, I was a chief nurse, which means the most senior nurse in a hospital, 3 acute hospitals, which meant that I'm responsible at board level, but also leading nurses and midwives. My last chief nurse post was at King's College Hospital in London. As you'll know, a very, very big and busy hospital. And I think we could all see the challenges within healthcare sort of leading up prior to COVID, frozen pay, increased vacancies, and then we did have the unexpected pandemic. And certainly at King's, at its peak, we had 780 patients with COVID, 140 of them on ventilators, which is something I will never forget, and neither will the nurses and midwives that I work with and clinicians. And I don't think we should underestimate the impact that has. There's some research that I heard 2 weeks ago by Surrey University called Forever Altered. And I think for many of us in healthcare, we are forever altered by what we saw and what we experienced. And for me, I think leading 7,000 nurses and midwives to do extraordinary things, it was a real opportunity for us to start really addressing some of the challenges in the NHS. But sadly, I don't think we did that as well as we could have done or should have done. So for me, I always thought I would retire working in an acute hospital, leading clinical staff. But I felt it was a time that the profession, particularly nurses, have had enough. And we needed to do something really quite drastic and different than we are doing. We've got highest vacancies we've ever had. We've got more nurses leaving than we've ever had. And since the pandemic, we are now so reliant on international nurses. 1 in 5 nurses in the UK and is now internationally educated. Whilst of course we welcome those nurses, there is no real domestic plan. And of those 1 in 5, 20% are from red listed countries where the World Health Organization had rather we leave their nurses in their own country. So I did decide to leave acute care, and I'm very proud to become part of Pat Cullen's team at the Royal College of Nursing. Started there on the 7th of December, and we've been there nearly a year, an extraordinary year. And without wanting to sound over dramatic, I genuinely believe this is an extraordinary time, that if we don't make some changes now, we will never see the benefit in 5, 10, 15 years. And I cannot emphasize enough what a crisis we're in. And we've got to be very careful at the college. We've got to highlight and be articulate about the genuine concerns, but have that balance of it is still a fantastic profession to join and be part of, despite university applicants being down by 12% this year. I love being a nurse. It is still a privilege to look after people at the most vulnerable time in their lives. Whatever your passion, you can do it in nursing. And we've got to both speak up the profession to get the brightest, the best, the most able to look after patients, but at the college also really be clear that there is a bit of a crisis that will need everyone to really get our heads together and see how we can solve this. So I'm delighted to be here, but I have to say, now is the time, I think, for all politicians, all parties, everyone to come together, because we need to solve this for the public and for patients. It's tragic that many nurses, if you listen to them during the strike action, they were striking for themselves, their pay, but if you listen to the next sentence, it was about safe staffing. What are we doing to make sure we've got the right number of nurses on shift to be able to really ensure that we look after patients safely? And that's going to be one of the key focuses at the Royal College of Nursing, is really identifying what safe staffing actually is, because we need that. We need that strongly articulated for the profession and for the public. I've probably done enough talking for a moment, and I'm going to hand back over to Ben.
Thank you. Very, very good, kind of interesting opening remarks, a sense of the crisis. I mean, I wanted to ask you, if you don't mind, to sort of describe a bit more around the kind of the causes of the crisis. What do you think has kind of led to the situation we see today in hospitals across the country?
I think it's been multifactorial. I think certainly in years gone by, there was financial support to be able to do your degree. You didn't have to pay. You didn't have to pay to be a student nurse. That was something that was part of the workforce plan, and you had a very, I think, a good bursary. What that also meant, and I've met many of them, there were lots of people that came into nursing and midwifery as a second career. I had nurses in my team that were journalists, barristers, all sorts of amazing people that came in as a secondary career. That is just not possible now. If you've got to pay your fees, your bursary, £400 a month in England, it's just not possible. And I think increasingly that the nurses are treated as every other student. They're not every other student. They can't get a secondary job. They've got their clinical placements to do. So I think we've absolutely got to look at pre-registration and think about what schemes we can put in to be able to make it an attractive career and set up the educational requirements right from the beginning. We've also got we've got to have schemes for local people who maybe don't want to go to university, but want to do it as an apprenticeship. And the NHS workforce plan talks a lot about apprenticeship models.
Yeah.
Absolutely fantastic. They want it to increase by 20%. But there's a cost to that. To put someone through an apprenticeship costs at least £18,000 per person. So a fantastic workforce plan, but it's just not going to be possible without investment. And that includes apprenticeships. So whatever model we have, whether it's growing local people through an apprenticeship model or a university, we need all of it. But all of it's going to take investment. There's no easy way. We need to change and invest in both.
That's really helpful. Polly, did you want to come in on any of that?
Yeah, I mean, I think kind of how we rebuild our workforces for the future, I absolutely agree, is going to take investment. Absolutely. No question about it. The level of need in the country now is growing and growing and growing. It will take investment. And that's a really difficult message for any government to hear at the moment when things are so tight. But I don't think it stops there. I think Nickola's point about reform is so crucial. And at Demos, kind of we've been thinking, I'm going to go slightly big picture at the moment, to the wider context and the kind of drivers of some of the crisis across public services. And our central idea about reform is, how do we get back to the principles of so many of our public servants that want to work in relational ways with people, that really want to connect with the people that need their services, not because that's a nicer way of working, but because it's a more effective way of working. So in Demos's public service reform agenda overall, we're looking at something called relational public services, which is, how do you get the investment to give public servants time on the front line, really working with people to prevent problems before they happen, whether that's in public health or whether it's in children's social care or social care, looking at really identifying the areas where we can help people to prevent all the problems that we're just firefighting at the moment. So kind of big picture, that's what we care about. But I ran a really interesting exercise about 6 months ago, where the central kind of message I was hearing across public services, and specifically about the NHS, is public dissatisfaction. People are really, really dissatisfied with what they're getting. We ran an exercise where we looked at all the different complaints bodies across the public services and looked at their rates of complaints before and after COVID. And across the board, they are still, 2 years after COVID, 23% above where they were. There is a real sense of tension, whether it's between families and schools over home learning, whether it's between families and their hot GP surgery over can they get an appointment, whether it's between benefits claimants and how they kind of access their benefits. There is just a sense of a breakdown of trust that is now inhibiting all the work we can do together to reform and get better. So that idea about relational public services that their primary focus is about how to work with people to prevent problems from happening, but also how public services can work with communities to strengthen and work together to prevent problems that happen as well. Like so many health problems, actually the true root cause are things like loneliness and isolation and not being connected to people. So what's the role of the state in actually building social capital and building a stronger society to prevent problems from happening? And I was really struck, last night we had Sir John Curtis, the infamous pollster, at an event, and he was basically saying the number one issue for any government is to improve the NHS and to reduce waiting times. But actually, I challenge the waiting times. I think he goes further than that. There are much wider problems in how people are relating to the NHS. But he showed this incredible graph which shows that since 2000, satisfaction with the NHS has far outweighed dissatisfaction. And then it totally flipped in the pandemic and has continued to decline. And, you know, I feel so much for people who work in the NHS, who know the problems there are, who know how stretched they are. at the moment. But rebuilding that relationship between individuals, communities, and our public services has got to be part of the reform agenda, along with investment. And by the way, the work we've done also starts to show that it's more cost effective to prevent problems rather than being a state of firefighting when things go wrong.
I mean, I can absolutely agree with that. I mean, from my experience, but bringing it, at a senior level and at patient level, really, I always think there's three things to always provide outstanding care. People want to be safe, they want to be cared for, and they want to be listened to. If you do those three things, you get it right every time. But with the system under stress and under difficulty, I don't think patients do feel, or the public feel, as safe. They're worried about access. They're worried about what's going to happen when I do come in. Are there enough staff? Will they understand me? And then I think, cared for is absolutely essential, and it doesn't take time. When someone cares for you, you can feel it. And I think, sadly, with the amount of scrutiny on clinical staff, we start to behave in a slightly defensive way without meaning to. And then when you put that in with, are there enough of us to look after people? What's the scrutiny? Sadly, the thing that sometimes gets missed is then listening to people. What do they really want? What are they really worried about? And actually, that is absolutely essential to keep people safe. And so I think it is, it is more than just, we've got to change the culture a little bit as well, and just create those opportunities, because without meaning to, we become a little bit task orientated, get the job done without thinking about, this is someone in front of us who absolutely needs our undivided time, attention, and care. And I think just really refocusing that, but most arrows in the end point back to safe staffing. They want to have the right number of people in order to be able to do the job brilliantly. And actually we've got to recreate culture, but it is also giving people the right tools. But I don't think we spend at the moment as much time really listening. And I think that would make a massive difference to the experience of people.
Do you want to say anything? Because, I mean, a big part of relational public services, there are a lot of relationships that we're interested in. We're interested in relationship between service and the wider community. I think there's a big role that services could play in actually better harnessing the networks around individuals in delivering services. Another obviously really important relationship is that between the provider of the service, the public servant, and the service user. And I don't know if you wanted to talk a little bit about the work that we've done around patient safety and that kind of relationship in particular.
So who here has heard of Martha's Rule? So I feel quite proud of that, because 4 weeks ago, no one had heard of Martha's Rule. And for those of you who haven't heard of it, it is a policy that we developed at Demos with a family whose daughter died in really horrendous circumstances at a London hospital. And essentially what happened to Martha, was her name. Her parents she had a horrible bike accident, but there were a whole series of infections thereafter. And 2 years ago, in the run up to the August bank holiday, her parents were terribly worried about her deterioration and expressing concerns to the medics. And they just didn't feel like they were being listened to. And actually, kind of most painfully, Martha was worried that she was going to die. And nobody responded to what was happening there. And her mother, Meripy, at one point actually said to one of the staff members, "I'm worried it's a bank holiday and that there'll be no one around and my daughter will die." And Martha did die on the bank holiday Monday. And subsequent reviews have shown that there were a series of really catastrophic errors to identify her deterioration, but crucially to listen to the family and to really hear their concerns. Merapy and Paul, the parents, talk about how they felt kind of managed. They felt like their expectations were managed. They weren't shared vital information. They were never told she actually had an infection or the severity of the infection, even though the medics know, because the medics didn't want to worry them. And there was no trust between them to really share candidly what was going on or to in any way listen to the parents. So what subsequently happened was that Merapy wrote a piece about their experience in The Guardian and was absolutely inundated with hospitals who were saying, we recognise this failure in culture to listen and respond in pockets of bad practice. Like, lots of people are absolutely brilliant at this, but we recognise there's a cultural failing in parts of the NHS to really listen to parents and patients and families. And we worked with Merapy and Paul to develop Martha's Rule, which is based on a mechanism in Australia called Ryan's Rule, which essentially transfers power from the medics to the patients. So where a family or a patient is worried that there's a serious deterioration, it gives them the power to trigger a clinical review. So it's not just asking for another opinion, it gives them the power to trigger that clinical review and to make a separate team of medics come and assess the situation. And all the evidence of where this has been practiced around the world shows that in the vast majority of cases, it's not abused or misused. But we think it's really important, not so that parents have that ripcord to pull, although they need it and families need it in the dire circumstances, but so it starts to trigger the culture change needed to really incentivize people to listen and partner with patients and understand that they know their bodies or their loved ones' bodies better than the medics, and sometimes that information is absolutely vital. We published a paper on this, and Merapy did a Today programme interview 4 weeks ago today, and by that afternoon Stephen Barclay had announced that they were going to explore it in the House of Commons. Wes Streeting confirmed that they will write it into the NHS constitution. We've since been working on a sprint with the Department of Health to develop the policy, to implement it, and we expect to kind of outline how it's going to work by the end of the year. And it's a kind of it's a symbolic to us kind of gesture to help change the culture and incentivize that listening. We hope no one ever has to use Martha's Rule. Ultimately, that is what success looks like. But the whole thing is about changing the balance of power between servants, public servants and citizens, and forcing a better conversation and better listening, and a partnership to achieve better outcomes.
Nicola, do you want to sort of set out any thoughts?
Yes, I do. I mean, I know Martha's case very, very well. It's absolutely tragic, but you're absolutely right about the missed opportunities to really listen. And I fully support Martha's law. I think it's great to always have that second opinion, that fresh eyes. I think it is, the right thing to do. But I think it is also right that we've got to shift that partnership. It is, your body, your life, your loved one, and really create that sense of not being so paternalistic, but really having that sense of equal power and investment to get it right, actually. So I absolutely fully support this. And I think many clinicians will, actually.
One of the things that was so interesting when we looked at the research of where this has been done in other countries is that it has to be really prominently displayed. So there's posters and stickers around the wards. But an interesting change happened, that they anticipated that it would be patients and families using this mechanisms, and it was, but actually other staff members started to use it. And in a lot of cases, nurses who felt they weren't being listened to by the senior clinicians actually found a way to use it. And in the best practice, actually the clinicians really welcomed it. and said that's the right thing to do because it makes us all safer. It adds to our armory of what can make things safer. But it said something to me about the dynamics within hospitals as well, and between different teams within a hospital.
I think that's what's not always fully, nurses are the largest workforce in the NHS, but they're also the constant presence for the patient. They are there morning, noon and night. Other clinicians can come, they can assess and they leave. And that's why nurses are so essential for safety. People think it's about care. Of course it's about care, but it's far more complex than that. Nurses are absolutely essential for the safety of patients, and they have to be brilliant. They have to be there. We can't have shortages, but they've also got to be top of their game. People still say to me sometimes, "Oh, Nicola, do you need a degree?" And there's people have just got to remember you need a brain and a heart to be a nurse. It's not one or the other. And keeping nurses up to date, keeping their education, CPD, continuous professional education, it's absolutely essential that's invested. We only have £300 a year per nurse at the moment to have that education, but it's not written into their work plan. They would have to do it in days off, or it's not that continuous professional education is not written in there with nurses as it is with other professions. And yet we are essential for safety. And you're absolutely right. Is it vital that nurses are that action if they're worried? So I think, if a nurse is worried, being able to get another opinion, if the team they're working with isn't sure, I think that's exactly something that I can see being utilised by nursing staff as well.
I'm conscious of time, and I like having lots of time for questions, but I'm going to abuse my privilege as chair to ask a couple more. I'm sort of here. I guess we're at Conservative Party conference. It's a political couple of days. The message I'm hearing is that healthcare needs a combination of investment and reform, and we've spoken in detail about some of the potential kind of new ways of thinking and a kind of very specific example of what that reform might look like. Taking those in order, kind of starting with investment. I mean, do you feel confident that we might do you feel confident that we're going to see the investment we need in public services? And if not, how can we change that? Because obviously investment is a question of money, and money is a question probably of taxation in this context. So what's your kind of message to the Conservative Party on that, if panelists have one? I'll maybe start with Nicola and then we'll come to Polly.
Yeah, I think it does require investment, and it requires change. And actually, I think that if you look at certainly, my role in my professional life has been hospitals, but there is a direct relationship with social care. And actually, and as you know, I did spend some time in the States. Now, I'm not remotely advocating the States, but what I did see was you weren't in hospital unless you needed to be. There was a flow, and I think some of those principles of we need investment in social care. We need pay parity. We need investment in the support and education of nurses and nursing support workers within social care, so that acute care is exactly what it needs to be. But also the other big crisis that we absolutely need support in is mental health and community, and it's all facets of healthcare. So I do think there needs to be investment, and I think just stop looking at just short-termism. That's what is making it very difficult to make wise decisions. We need to make decisions now that we may not see the benefit of for several years to come, but we have to do that rather than just sound bites, and it needs proper reform that may take a few years to see the fruits of our labour, really. So I think that absolutely has to be done. Social care, community, hospice care, all of it has got to come together with at the centre the patient and the person. Because what is very, very upsetting for patients is we talk about the NHS and they're expecting one big system that works together. It's so frustrating, the amount of paperwork that people have to fill in. It doesn't flow. It's very difficult. We've got to change the way we work, but we also do require investment in all aspects of healthcare in order to get it right for patients. And I think that is multi-pronged, but it does require action.
So a plea for long-term thinking, which I think is the Prime Minister's new slogan. So maybe we'll we'll see that.
But you see, as you walk in, it talks about waiting lists. The waiting list is one small part of it. Though they're the worst, the highest, waiting list that we've ever had. But let's be clear, they were building up prior to the pandemic. Now, I'm old enough to remember when 98% A&E target meant 98%. No patients in A&E, no more beds in A&E. The 2-week rule, you absolutely got it. What frustrates me is when people say, oh, it's just too difficult, it's just too clunky, the NHS is not doable. It can be, if you invest wisely, we can do it. But the key to that, there is no NHS without workforce. There's no NHS without staff. There just isn't. And that's what requires an investment. People are totally capable of looking after patients in the way they need to be cared for. But we've got to invest in the workforce and get this right. Otherwise, I really do worry about the NHS's future.
I'm going to violently agree with that, but then hopefully say something controversial as well. Now I've promised I've got to. So the key word I heard there was investment. And I think we need to be clear about whether we're talking about spending or investment. Are we spending more on what we do at the moment, or are we investing for a different kind of change? And one thing we're doing this with, we're publishing a paper this week making the case for a new stream of spending in the Treasury for prevention. So at the moment, government departments get capital spending and departmental spending, which is their day-to-day spending. We're making the case for a third stream of spending called PDEL, which would allow departments to pitch for long-term investment in reform and create incentives over a much longer period to invest for the future and the future services we need. Which would make the accountability different, but also send a signal across the system that actually investment in the future matters and prevention matters. Because I think your point around why all the bits of health and social care that aren't in hospitals is really, really important. And that's the controversial thing I want to say, which is I think hospitals get too much focus and gobble up too much money. I love hospitals and would defend them forever. But actually, if we put the investment outside hospitals with the main aim to keep people out of hospitals, that's how to say, why you're nodding? That was meant to be massively controversial.
Where's the controversial bit for?
I thought that would be more controversial, sorry.
No.
I just think thinking about health and social care, but also wider community strength and cohesion is actually the route to solving a lot of these problems later on down the line.
You're absolutely right, because it is investment spending. We spent £2.4 billion on temporary agency workers in England. So actually we're spending the money, but we're not spending it wisely. It does require investment, and to do it properly. And that's the issue, because poor care costs more. We know that. The evidence is there.
And I think politically in this moment, it matters so much. Like the next government, any successful, a two-term government of any colour, is going to have to solve the NHS crisis. It's going to have to come up with a solution here. And the thing that I love about conversations around the NHS is the complexity with which the public hold the NHS. We're about to publish a report around communications with the NHS that we've done in partnership with a brilliant charity called Engage Britain. And it's called I Love the NHS, but because people get that. People understand that they would die in the ditch for the NHS, but they also struggle with it on a day-to-day basis, whether it's getting an appointment or getting a referral or getting life-saving treatment when they need it. People know it's not working, but it matters to us so much as a nation.
Right, so
I might take some questions from the floor because we've got such a oh wow,
I think that was a popular.
gosh. I honestly don't know whose hand went up first, so I'm going to randomly pick people. Andrew's ready with the microphone. Please wait until you have the microphone. If you could ask your question and then say who you are and your organisational affiliation, if you have one. So I'm going to click in the front row here. I'm going to randomly go to
Go in threes.
Threes around?
Just so the microphone doesn't
all right.
travel.
I was going to be very
I'm his
adventurous.
boss, so I'm being bossy,
No.
sorry.
So yeah, 1, 2, 3. Did you see that, Andrew?
Hi, thank you so much for that. I'm Philippa Mariani. I am Chief Executive of Think Ahead, which is the charitable organisation that attracts and recruits and trains mental health social workers. So all the things that both Nicola and Polly were saying about integration of health and social care and how important that is very, very close to my heart. And a lot of the things that you were describing about recruitment crises in nursing, as well as in people leaving the profession, are absolutely common to social work in general and mental health social work in particular. And social workers are absolutely undoubtedly the glue between people who are being discharged from wards and the ongoing support that they might receive in communities. But in some areas, there are up to 27% vacancy rates at the moment, and those teams are literally buckling under the weight of workload, as you mentioned, Nicola. And you drew the points about patient safety very, very effectively. There's also another point, and that's about the mental health of the mental health workforce itself. People are leaving because they simply can't get the support that they need to look after their own mental health whilst they're doing these absolutely crucial jobs. And we know that about 1/3 of sick days in the NHS and in social care are as a direct result of people with mental ill health as a result of stress and strain and overbearing workloads and requirements. So my point is this: we are, as a party political conference, and I, for one, am deeply disappointed not to see a minister on this panel. Thank you. I'm deeply disappointed that Maria Caulfield, who's the Minister for Mental Health, isn't here, because mental health is such a cross-cutting theme around the things that we're saying. And I'm also deeply disappointed that social work and mental health social work in particular is not mentioned in the NHS Workforce Plan, which was published quite recently. And if Maria had been here, my question to her would have been, why not? And what can we do about that? I don't know if our panelists can answer that, but I put it out there.
Thank you for your question. We're going to go to the gentleman behind. Thanks.
Hi there, Alex from Macmillan Cancer Support. Talking about the long-term, obviously the long-term workforce plan, I'd be interested for your thoughts on the long-term workforce plan. I know there's some funding been allocated, I think 2.4 billion, which I understand is around education or training. But I'm more interested around the retention part of it, and whether you had any thoughts on what was in it regarding retention, or is there anything that's not in it that you think should be in it. So yeah.
Thank you, Alex, and then to the right there.
Hi, happy days. We've hit 3 charity people in a row. My name is Jane Lyons, and I run something called actually Cancer 52, which is a coalition of cancer charities working in rare and less common cancers. So that's everything outside the big 4. That's 115 of them. So I've got a couple of comments and a couple of questions, but I'll try and keep it quick. There's nothing, worse than a great big speech. So I was going to make a professional type comment, a personal type comment, and then just to try and throw in a bit of political whatever, because we are where we are.
Brilliant.
So my professional one, the Cancer 52 one, really, is about, we kind of touched on waiting lists and then moved away from it as a significant thing. But if you work in the cancer charity sector, waiting lists are up there as workforce diagnostics waiting lists. Bing bong, cannot get rid of it, especially in cancer. I mean, there's a topic and there's something that needs to be fixed. So can we have a comment on how important that really is? I was very interested in the difference that I think I now understand between investment and spending. Investment is long term, and spending is like now. And like, no, well, I'm just saying,
I agree.
Trying to get the difference. So my question really about investment, and also we've got the political message on the building, is I think with everything to do with this, we as the great public have to understand what is investment and what is spending, and whether any of us as the wider public are ready to wait for the benefits of the investment. I get it, totally, but whether you're ever going to win an election, therefore political force behind it to say we're investing in the future, so if you just hang on a bit. I'm not sure you win much on that basis. But finally, back to kind of wrapping it all up again, and the thing that hasn't come up of pressure on the NHS thus far, and this is wrapped up in cancer as well. Cancer is largely a disease of age. I know it happens at other times and everything else, but the thing that keeps coming up, obviously, is that I'm also contributing to the other massive pressure on NHS, which is I'm getting older. And bits are falling off, and I'm getting multiple morbidities, and I'm an absolute candidate for multiple major condition strategy. I mean, multiple morbidities, etc., etc. And none of you have mentioned actually we're going to have this vast aging population that are all going to be getting autobus outside your lovely hospital. And just finding one personal point, my absolute aim is to stay out, because I think if I've done that, I'm doing reasonably well. Thank you.
Wow. 3 very comprehensive questions / comments. So to sort of summarise, number 1 was around mental health, social work, and why isn't that included in the conversation today, and some reflections on how that might be covered. Second question was, I think, asking you essentially for your remarks, Nicola, on the long-term workforce plan in the NHS. And then Jane's final 3 points, which I think are really interesting. Waiting lists are very important. Number 2, the politics of investment versus spending, which is something that we spend a lot of time talking about at Demos. Really great question. And then point 3 was around aging society. And how does that relate to what we're talking about today? Nicola, is there any of those that you want to pick up?
I think all of them were essential, actually. I mean, social work, you're absolutely right about social workers. And what's not always understood, which you will know so well, is that social worker is the glue that sees people in their home, follows them both into hospital and out, or wherever they absolutely, and social workers are absolutely key, and I don't think are given enough investment or attention, but also not fully a great deal of real credit of the huge pressure social workers are under, who are making decisions that when they go well, no one says anything, but when they go wrong, it's very quick to criticise. And that personal pressure on social workers is not always understood, particularly in mental health, actually, where you're making very difficult decisions, whether to keep someone in the community, bring them in, all of that complexity. So absolutely support that they are essential, and we need to do more to highlight that. With regard to the workforce plan, I don't think enough is put on retention, and what does retain people is time away from the patient to be educated and reflect, and that isn't really stated clearly enough, particularly for nurses, where most of their funding is directly encouraged to be hands-on patient care without that real investment in time away to educate and to develop. And I think the average master's degree costs thousands, and yet £300 a year goes nowhere. So there is something about really investing in the workforce plan for CPD. Absolutely agree with everything you said about cancer, particularly around diagnostics. And I can remember when all of that peer review and cancer reform started by Mike Richards, organisations met those targets with pride, and there was a very, very robust cancer peer review process that did lead to extremely high standards in cancer. And I do believe that is going the wrong way. Your point around investment and spending, the real tragedy of this is because healthcare is so essential. In the moment, we have to do both. We can't wait for the investment. People need care now. That's why you have to spend at the same time as you sort out a workforce plan or whatever we're doing. We need nurses now, which is why 1 in 6 of our nurses is international, because we can't just say, oh, we need to wait till we get all of this right. So I appreciate that we have to spend, but if that is your only policy, to spend without a long-term investment, that's when it goes wrong. And that's the bit that needs to be understood. If we just have this short-term spend in the short, without that investment, then eventually you can reduce the immediate spending you're doing. Now, the States did this. I was part of their nursing workforce shortages. Lots of us in the UK went to America when they had a workforce shortage plan. They sorted it out. They increased the number of graduates. They made it a profession that was well paid, well valued. They can do their workforce now, on the whole, is homegrown. And so it's possible. But now is the time to just stop this short-term spending and start with some long-term investment that will, I do believe, we've got to have a degree of optimism. Otherwise, if we don't think this is solvable, we might as well all go home. And that's my urgency, is I really believe, the RCN, we absolutely believe this is solvable, but it's the will, the investment, and to really put patients at the centre. And if you want to look after patients, you've got to look after the staff.
Just two brief points to kind of add to that. One was on the kind of mental health side. There's the political urgency to improve services to people. I think the link that's not being made enough is how much that's holding back economic growth at the moment. So the workforce problems across the economy, caused by mental health problems. We've had our mind really focused on it with the kind of economic inactive group, particularly in later life, but actually that's now playing out across age groups, that mental health is stopping people working and it's limiting economic growth. So if you think about probably what I think any government's 2 big agendas have got to be growth and sorting out the NHS and wider public services, it's central to both. And on your point of what's the political argument for long-termism, I mean, it's a really good question. We've got to have a more honest conversation in politics and with society. People can see what the scale of the problems are. People can see how much things aren't working at the moment. And we can't pretend that that's going to be fixable overnight. Workforce plans take generations to fix. Stopping cycles of failure in kind of some of Britain's most troubled families take generations to fix. But that's the only way we're going to actually limit the need on the state as well. So I think a more honest conversation in our politics, that we're not in a quick win situation at the moment. We've got to invest in the future.
Some optimism.
Yeah.
Sorry.
I didn't answer your question about getting older.
Oh yes.
I mean, I have to admit that is something we're all going to do.
Well,
I'm not sure that we really are doing enough public education around what kind of older life do you want. I'm very clear with mine, and the standard of life I would want as I get older, but I'm planning that. My advance directive, all of it. We don't talk enough about something we inevitably, not all of us will get cancer, not all of us will break a leg, but we'll all get old. And there isn't really enough. We talked about partnership, really discussing what sort of old age what's the standard of life that you want, and how do you become a genuine partner in that conversation. It's tragic how often we're between families, between individuals, those conversations aren't happening, and then we sometimes don't treat the person as a partner with regard to the future they want. Exactly.
Cool. We're going to take some more questions. We're going to go over to this side. So Andrew, make your way over there. Yes, one at the front. Was there one behind? No? Okay, so one here, and then, so we're going 1, 2, and then behind 3. Over to you. Yeah, just question and should just work name and organisation as well would be great.
So my name is Corinne Turnbull. I'm here as a patient representative for the Royal Osteoporosis Society and the Sunday Expresses Better Bones. And I think this has been a fascinating discussion this morning, and it's picked up on so many themes about the things I just wanted to kind of comment on really. Ageing and ageing well, and the disparity that we see. The campaign that the Sunday Express has been running around Better Bones is about the iniquity of fracture liaison services in England, and the fact that only 50% of NHS trusts in England have one. Those services are there to identify anybody who comes in with a fracture over the age of 50 and prevent them from fracturing again. And if you consider that we have 1 million acute hospital bed days that are given over to get fractures in the elderly, it doesn't feel like a good use of money. That's spending, but really the investment for £1 we spend on fracture liaison, it saves £3, £3.25, sorry, I can't remember my exact numbers, but it's a 30% return on investment, and that's how we should be thinking about this. And I think that would also support your workforce pressures, because you're placing less pressure on those acute bed days. So would the panel agree that fracture liaison services is one really good example of ways that we can invest better and support our workforce in the NHS?
Yes.
And please, could we do something about it?
So I'm James, I'm a doctor in Birmingham, GP and a consultant as well. Since medical school over the years, I've just seen health secretaries come and go, very reactive policies, trying to get quick wins all the time. I've seen colleagues who are trained in medical school, excellent doctors, they're in Australia now, they're in Canada now. Because in reality, if I move there, I get paid 2 or 3 times more money. I've worked in the United States, worked for Mayo Clinic, worked in New Zealand, Australia. I've seen all these healthcare systems. The biggest problem we've got in this country is we don't have a long-term plan for NHS, okay? What we need to do is get, ideally, some leadership, because the leadership, politicians are very, very weak at the moment. The Health Secretary and others more interested in not tackling this because it's a big problem, it's complex, but I believe, and I can see the problem myself, it's frustrating, is that it is fixable and there is a way forward here. But we need some proper leadership, like Demios and other think tanks, to come up with a proper plan, okay? Because I know you've got some really good ideas, you've come up with some ideas today, but I'd like to see you and other organisations and the politicians come up with a proper plan. It should ideally be cross-party. I know that's very, very difficult to become, but long term, we should say, look, the NHS is a fantastic institution. There's so much great care, so many great people working in it. But we have to say this is one of our national treasures, and we need to come up with a plan, and for the long term. And I'd just like to see what the panel think about that as a possibility, and how do we get to that? Because I really want to see that happen. Okay, thank you.
Thank you, James. Yeah.
Hi. I'm a graduate nurse from way back, and this idea about money coming out of the hospital into the community has been around for quite a long time. And until my mother was going through her current situation, I would have agreed with that. She's in her late 80s, and she is having lots of nice ladies coming in and out of the house. She's a former lawyer with some autism, and some are quite risk averse and very caring, do almost everything for her, and others are emphasising independence. So lots of different ideas coming in and out, and as she gets older, it can be quite confusing. And then after a while, going to the toilet becomes tricky, and then she gets infections, and then she has to go in. And so, I mean, this continuity of care is heard all around the place with respect to nursing, and of course it's expensive. But that is one disadvantage of community care, where you've got lots of different people coming in, like 3 or 4 times a day, with slightly different ideas about, careful about falling, oh no, have a go about, take a risk. And then there's also legislation about, I think care homes are being assessed on their fall, or is that just in the States?
They certainly have to report that to the CQC. They would.
So some care homes start to get really very protective about people falling. But in the hospital, perhaps, or some carers will be saying, no, take a risk and lie on the floor and wait till we come in the morning or something, won't they? So I'm wondering whether that's contributing to dementia, to be honest. So I don't know what other people think.
Yeah, cool. So a question then at the end around kind of continuity of care and some of the issues around that in someone's real life experience. A question from James around kind of health secretaries kind of seem to come and go. How can we actually get on a proper long-term footing? And then a question from Corinne around specific proposals around a fracture liaison service. Is that correct? Don't know. Polly, do you want to pick up
Comment on
anything?
the fracture liaison service. I think there are so many examples of this, of where a bit of investment here would help over there. So I don't know the specifics of that, but it sounds like a really clear case for improving people's lives and saving money long term. Cross-party commission on the future of NHS, yes, please, we'll do it. But it does need to be cross-party. I think it's a really, really good point, and politicising the NHS is not helpful. It's not, and the problems are, obvious and real. You can't interpret them differently, and the solution needs to be long-term. So I couldn't agree more on that. And the last piece around what I interpreted that about kind of what reform might look like. And if you think about our health system at the moment, it's a little bit factory line. You kind of go to the GP, they refer you to something, you go to that stage, you go to that stage. Actually, if you were going to design it from scratch, what would it look like if it was based around the individual? What would that whole experience? I can't tell you what it would look like, but it would be very, very different in design. It would be much less about institutions and much more about that individual's need. And I think kind of were you to do the commission, I think kind of asking really challenging questions like that would be really important.
Yeah, I was just going to say your point about fracture. When I was at King's, a big trauma centre. So you've got the, head of trauma coming to talk to me about what we need to do, and I thought he was going to say something about massive head injuries and the car accidents and the stabbings and all the other things. It wasn't. It was how do we stop people falling and fracturing. So your campaign is absolutely vital, and actually really supported by trauma centres, because that is the majority of trauma. And you're absolutely right. I think it's a brilliant campaign. I know the RCN has supported it because I think it is absolutely vital. Your point about, we've got to have, as I said earlier, proper long-term thinking. What's interesting about Australia is 1 in 4 nurses in Australia is trained in the UK. And that's the tragedy. Why are they there? Because they have safe staffing legislation and ratios. I've got the chief nurse from Australia coming to the RCN in December because we have to learn. Because what they're very clear on is their safe staffing. Victoria has been way ahead of ratios. The research is there. Have the maximum number of patients that any registered nurse has to look after. We will both recruit and retain if we are stronger in that space. So we do need to see what Australia are doing and doing well. Pay and conditions in Australia are absolutely right. And your point about continuity of care, it is so fractured. And actually your point is absolutely key, is to get care right, someone's got to lead it rather than all these fragmented views. And the difficulty is where patients get caught in the middle is when everybody is covering their own bit. So like the CQC, nursing homes, they will, any fall, it'll be investigated as it is in hospital. Sometimes we stop people getting up and moving around because we're fear of them falling over. Nursing homes are reviewed by the CQC as to how many deaths they have or whether they require investigation. Actually, if that's your home and your nursing home, that may be where you want to end your life. So the unintended consequences of scrutiny sometimes don't help us be really strong in that continuous care for patients, whatever the system that they're moving through. And I think if we were going to make the patient at the centre, we'd radically reform that. Radically reform that. All these constant handovers. it's just not right for patients in the long term.
Well, we're out of time, but a cry for radical reform always seems a good note to end on. I know there were many questions which we didn't get the chance to come through. I'll certainly be here. I'm sure Polly will for a bit afterwards. So come and badger us, but warm round of applause for yourselves and the speakers. Thank you very much. Great. Yeah, really good. I love international examples. So,
Oh, good.
I mean, that's a very wonky way of putting it, but we love them. We love a good think tanks, love an international.
Oh, brilliant.
So,
Well, we're
it's really great to hear so many. Thank you. Yeah.